Hello, everybody, and welcome to this episode of the Neurology Video Journal Club. My name is Dr. Sarah Brooker. I'm a Movement Disorders Fellow here at Northwestern University in Chicago. I'm joined today by Dr. Rizwan, an Assistant Professor here in the Movement Disorders Division at Northwestern.
Hi.
Cool.
Welcome.
So today we will be discussing this recent publication in the journal Neurology by Christopher Gibbons and colleagues. And the title of the paper is Cutaneous α-Synuclein Signatures in Patients with Multiple System Atrophy and Parkinson's Disease. So I was thinking I'd give just a kind of brief overview of the study, and then we can get into some of the details and discuss further.
Sounds good.
So in terms of the objectives here, the authors were set out to find a cutaneous biomarker signature that could help to differentiate patients with multiple system atrophy from patients with Parkinson's disease and also healthy control patients. And their hypothesis was that combining cutaneous evaluation of synuclein staining and the distribution of phosphosynuclein within the skin, combined with also looking at nerve fiber density, could potentially allow them to find a pathologic signature that would allow them to differentiate between these two disorders. And to test this hypothesis, they recruited patients with MSA, PD, and healthy controls, and did multiple different analyses that we'll get into later.
Mm-hmm.
So, Rizwan, before we get into some of those details, what are kind of your thoughts about the study in general and how it fits into the field?
Yeah. Well, we know that clinically distinguishing MSA from PD, particularly at early disease stages, can be challenging. And there's a huge impact in making an accurate diagnosis on the patient. If you can identify a patient with MSA, they are potentially candidates for research trials. You can properly advise them about what they may expect over time. And that progression of MSA is very different than what most patients with Parkinson's disease experience. So the more tools we have to make that diagnosis earlier and more accurately it's very important in clinical practice. And then on the biologic side, there is a question as to why patients develop either Parkinson's or multiple system atrophy, despite both of them being synucleinopathies. And there's been a number of different studies that have looked at brain synuclein and the differences between those conformations that suggest that synuclein in MSA is acting differently than synuclein in Parkinson's disease, and getting access to those compartments and looking at the brain's hard. And so if there's a way that we could detect these differences cutaneously in a compartment that's much more accessible, we might learn something about why these diseases first start and why they progress so differently.
Absolutely. And so then getting into how they kind of set out to go through that question, what the authors did here was they did a prospective multi-site single visit cohort study. And they recruited patients over a 5-year period between 2016 and 2021. And this included ultimately 31 patients with a diagnosis of MSA. And that was based on the 2008 consensus criteria. They had to have at least criteria for probable MSA. And then for the PD cohort, they ultimately recruited 54 patients with criteria for definite PD based on the UK PDS criteria. And in particular, they looked to see if patients with PD had a diagnosis over a 5-year period or symptoms over a 5-year period, and also whether or not they were levodopa responsive. So trying to really make sure that their PD cohort really was a PD patient population. And then the control patients that they recruited had no known medical conditions. And for all of the cohorts, they had some important exclusions. Anticoagulation was one. Also, any diagnosis that could cause a neuropathy was another, just because that could complicate some of the downstream analysis that they ended up doing. And from these cohorts, the MSA population had, on average, a disease duration of close to it was 3.4 years. Whereas the PD population had an average disease duration of 4.9 years, so close to 5 there. So what are your thoughts about the recruitment that they did and kind of the exact cohorts that they were studying?
So I think that the first thing that stands out is the fact that they recruited 30 MSA patients. I mean, there are 3 sites, but still that's a good number. And many MSA trials, both observational trials as well as interventional trials, struggle with recruiting MSA patients. So I think that's a commendable thing. They did a really good job actually matching for gender and for age within all the cohorts. I think the healthy subjects, they recruit the best they can and screen for potential neurologic diseases. I think that was reasonable too. And the fact that this is a multi-site study is also good. Although I will say, when they come to this later, that it's not clear how many of each of the cases were recruited at each of the 3 sites. This was not a single site study, it's a multiple site study, and I think that's also very, very good.
And then in terms of how they analyzed these patient populations, there are a few different things that they did, and ultimately they combined all these metrics together in the end, which we'll get to. So first of all the patients had detailed neurologic exams and specific MSA and PD rating scale analysis. And then they also did fairly detailed autonomic testing for all of the patients as well. And then from the pathological side, the main outcome measures were these cutaneous findings. Particularly, they did skin punch biopsies from 3 different sites, including the posterior cervical site, the distal leg, and the distal thigh. So 3 different sites for each patient. And from those skin biopsy specimens, they did immunohistochemical staining, particularly did staining looking at just axon and nerve fiber density with this marker PGP 9.5, which is a general axonal marker. And then they looked for co-staining with synuclein or phosphorylated alpha-synuclein within these 3 different biopsy sites. And they did some detailed analysis of the structures within their biopsy specimens, specifically looking at intraepidermal nerve fiber densities. And so the way they defined that was nerves that were crossing the dermal epidermal junction. And then they also identified different structures in the skin, sweat glands, and pilomotor nerve and pilomotor structures, and then had detailed analysis for how they would quantify the nerve fibers around those structures too. So kind of allowing them to look at different types of nerve fibers within the skin and whether some would have a greater ability to differentiate between these disorders.
So I had one point to make, and depending on who's watching this and what their experience is, the idea of getting skin biopsies from a neurologic patient population might be new, but the reality is that skin biopsies are fairly routine and straightforward to get in clinic. When you think forward and wonder, okay, is this assay, the whole development of this method, something that can be translatable to a general clinical audience? I think the answer probably is yes, because I think that these types of biopsies can be obtained in most ambulatory practices. So I think that's a very, very important piece. All 3 of the biopsy sites were treated the same. All of them were prepared as frozen sections and then evaluated with confocal microscopy. And they did, we'll get into this a little bit with the data, but they did take a lot of effort to try to quantify, as you say, each of the nerve fiber densities, both the afferents and the efferents. And previous papers have not gone into that much detail, I think. And I think that's a commendable thing also of this paper, that they try to identify exactly what is the nerve fiber that they are seeing in the skin that's synuclein positive, quantifying that as such, and then looking at the data subsequently.
Yeah, and an interesting or an important point too about how they quantified the alpha-synuclein or the phosphorylated alpha-synuclein in their biopsies is that they specifically looked at phosphosynuclein staining that co-localized with these nerve fiber structures. And then they, for each positive synuclein structure, that counted as 1, and they summated the total that they got there. How does that kind of compare to how other studies looking at cutaneous synuclein have done?
Yeah, I mean, so there have been some studies that have looked simply at alpha-synuclein expression, and by using a phosphorylated synuclein antibody, the assumption is that any immunostaining seen must be pathologic because it's phosphorylated synuclein. We don't think that phosphorylated synuclein is a part of the normal physiology of synuclein. But the structures themselves in the skin, they don't always look like the structures we see in the brain. They don't look like Lewy bodies necessarily. And so there's been this question about what is the relevance of the deposits in the skin with respect to disease. Maybe it's an artifact of some kind. And so in this paper, by first identifying that, yes, this is a nerve fiber that we're looking at in the skin, there's a specific marker for that, and then determining whether there's phosphosynuclein in that. I think that's a strong thing. You can't really do that very easily unless you're doing control and unless you're doing relatively large frozen sections like these.
Okay. And then, so just kind of diving into the results that they had here. So first of all, what they focused on was just looking at the total number of nerve fibers within these different biopsy sites and breaking it down into those different types of nerve fibers that they laid out. And in particular, what they found is that in the patients with MSA, that the intraepidermal nerve fiber density was not different between the MSA and the control populations. Whereas if you look at the PD patients, the intraepidermal nerve fiber density was significantly lower in the leg and thigh if you compare the PD patients to the MSA and the control patients. So lower nerve fiber densities in the PD population there. And a similar result was found when they looked at the pilomotor nerve fiber density too, where it was lower in the PD population compared to the MSA and controls.
Yeah, I think that's actually very striking and it's kind of surprising finding of this paper, that basically the density of the intraepidermal fibers, as you move from a caudal to a rostral to a caudal direction in the PD subjects, tend to go down. And that's not seen in the MSA cases, and it's not seen in the control cases. And I think if you look at table 3 in the first 3 rows, you'll see that even in the controls, there is a loss of about maybe 50% of the nerve fibers in the distal regions as compared to the cervical, posterior cervical neck. And that's seen in the control sections. And it's also seen in the MSA cases. But there is a dramatic in the Parkinson's group as a whole. About 80% of the intraepidermal nerve fibers are diminished. And so that's a bit of a surprising thing. And as we'll talk about later, it's important observation to note when looking at the final analysis.
Yeah, and if we look a little bit at figure 1, where they show exactly what this immunostaining looked like, we can see that gradient depicted that they described here. So if you look at the left side of this figure in the images that are traced in purple, those are representative images from an MSA patient.
Right.
And so you can see the synuclein in red and the axon marker, the PGP 9.5 in green, and the nice colocalization there, actually at all 3 sites. So in the cervical and in the thigh and the leg regions.
That's right.
And comparing that to the Parkinson's population in this figure on the other side, on the right-hand side of the figure, you can see the nice colocalization fairly well in the posterior cervical and also the distal leg region, or the distal thigh rather. But lower down in the leg, they're showing that there's an absence of phosphosynuclein staining here. So this interesting difference in the distribution of how the synuclein is distributed in these different parts of the body. And breaking down the numbers, what they found overall was that in all of the patients with MSA, they were able to detect phosphorylated synuclein at least one biopsy site. And for 94% of the PD patients, they found phosphosynuclein at least one biopsy site. For none of the controls did they find synuclein. So telling us that seeing phosphosynuclein in the skin is a good, reliable marker of these synucleinopathies here.
Do you want to look at figure 2 now?
Yeah, sure.
I think figure 2 really shows this difference in distribution quite well, and also illustrates the density of synuclein positivity in the MSA cases and how that differs from the PD subjects. And so you can see here in the leftmost column that's labeled PC for posterior cervical, there's quite a bit of alpha-synuclein positive deposits in that region in all of the nerve fiber endings. Actually, this includes all 3 biopsy sites, and that is similar in all 3 of the different regions. And as in comparison, the PD patients primarily have synuclein deposits in the paracervical region and have more spare positivity in the other regions. And I think what's really fascinating with this data is the heterogeneity within the MSA population, right? That some of these patients, for example, the third one here from the bottom, have very little phosphosynuclein deposits in the posterior cervical region, but in the distal leg, there's quite a bit. And there are other patients that follow that same pattern that you can see here. This patient here is similar. Whereas there are other patients that have much more posterior cervical positivity and less positivity distally. And then there's a third group that have sort of positivity everywhere. So I think this is a very interesting thing, that there's quite a bit of heterogeneity, even within MSA, for where the synuclein deposits lie.
And one thing that would be interesting to look at there, which perhaps wasn't quite in the scope of this paper, would be to see within those different patterns of distribution, even within the same disease, are there clinical differences? Whether it's related to the disease duration or the disease phenotype would be really interesting to see if there is a difference there. And another thing that you can take away from this figure visually is just comparing the PD on the right to the MSA on the left, that the total amount of synuclein represented by the size of those circles is significantly higher in the MSA population.
Right, quite a bit.
Yeah. And so they did have a mathematical way of kind of quantifying this posterior gradient that they found. So they called it a distribution coefficient. So the way they calculated it was a value closer to +1 meant that synuclein was only present at the cervical site. A value closer to -1 would mean that synuclein was only present in the distal leg. So for the PD, the distribution coefficient was 0.64, so fairly close to 1, representing what we just talked about here, how there's more synuclein in the posterior cervical site. Whereas MSA is close to 0, is 0.04, so kind of more of an even distribution, but from patient to patient, quite variable too. And they use all of this analysis that we already talked about. So the nerve fiber density, the phosphosynuclein quantification, this distribution coefficient, and then they use that to try to figure out, can we combine these metrics to get a good sensitivity and specificity for differentiating between these disorders? And that's something that we can see kind of depicted in figure 3. We'll pull that up as well.
Yeah, and so I think that this distribution coefficient is a good way of trying to capture what visually we saw in that previous figure in a mathematical way. And it makes sense in the sense that if you're closer to 1, you have more positivity near the neck. If you're closer to -1, -1, you have more positivity distally. If you're at 0, you're equally distributed. And that's what's shown here on the x-axis. And so what is your first takeaway from this graph? This is figure 3A.
Yeah, so a few different things. I would say looking at the y-axis there, you can definitely see that the MSA patients with the black dots, that they tend to cluster in having a higher level of phosphosynuclein. And that's, a fairly clear difference between the PD and MSA cohorts. The other interesting thing is looking at the distribution coefficient. The PD patients tend to cluster close to 1, like we had talked about, and that cluster of patients looks quite different from the rest that we're seeing here.
Yeah, it's very fascinating. To me, it seems that there is one subgroup of PD patients that have primarily phosphosynuclein deposits in this paracervical region, and then there's everybody else. And amongst everybody else, they can have a distribution that is even, or a distribution tending towards the posterior cervical region or tending towards the distal leg. And within that group, it seems like it's the severity of the phosphosynuclein deposits that predict whether a person has this biopsy came from an MSA case versus came from a Parkinson's patient case. So very, very fascinating. The question is, what is different clinically, if we know anything about these people out here on this side that seem to have spared distal phosphorylation.
And getting to their goal for the paper of differentiating between these two cohorts, the cutoffs that they show here, so the cutoff for the distribution coefficient and for the phosphosynuclein did allow them to find a high sensitivity and specificity for differentiating these two cohorts. So specifically, when they use the phosphosynuclein total cutoff of 7, which is shown on the line in figure 3, and then a distribution coefficient cutoff of 0.5, the sensitivity for identifying MSA patients is 96.8 and specificity is 98.1, so really high. But in figure 3B, you can see there's other combinations that they can do to get to a similar sensitivity and specificity. In that case in particular, they're showing how nerve fiber density is another metric that helps differentiate really well between MSA and the PD cohorts here.
Yeah, so we saw in the table 3 that already those PD subjects have lost intraepidermal nerve fiber density, apparently, compared to the MSA cases in general. But then again, it's the severity or the burden of phosphorylated synuclein positivity in these regions that predicts or separates the MSA cases from those that have PD.
And one thing that's interesting is kind of putting some of these findings together. So there's this reduced nerve fiber density in the PD population. There's the higher phosphosynuclein in the MSA population. And how do we kind of interpret those together is an interesting question.
Yeah, I think that this will bring us to sort of the overall discussion points and takeaways, I think, from this work. And, again, this finding of the decreased numbers of nerve fiber density in the PD subjects is very interesting. And, it makes you wonder, are we not seeing as much phosphorylated synuclein deposits in the PD subjects distally because we've lost the nerve fibers? Not there. And so we can't tell that they are phosphorylated, full of phosphorylated synuclein or not. And so does that change reflect disease state? Does it reflect disease duration? We know that they were matched, at least in disease duration, but we also know that the actual pathologic process probably doesn't take the same amount of time in PD versus MSA, right? The pathology is probably present much longer in the PD subjects before they finally get diagnosed. And then from diagnosis, the disease duration is equivalent. So is that the issue? If we had looked at early PD subjects in this study, when the question is still open whether they have MSA or not, when they're early on in the observation period, would they have a different nerve fiber density and maybe more phosphorylated synuclein in those regions, and maybe it's lost over time? I don't know.
Yeah, because theoretically, if there were more positive synuclein fibers distally in those PD patients early on in the disease, maybe they died because of some pathologic effect of the synuclein itself. So it's hard to say. And that gets to another point, which is in this paper, they found fairly convincing results that they can distinguish between these two populations. But one thing to keep in mind is that at the point when the patients are evaluated, they're a good deal into the disease. The PD population had the disease for at least 5 years of diagnosis. So at that point, it's maybe easier to distinguish clinically, whereas patients who are seen when they're really early on in the disease, that's a population where it would be great if we had a nice way to differentiate between them. And it's hard to say whether the findings we see here would kind of extrapolate to that population.
Yeah, I think one of the questions that was indirectly being addressed by this paper was, can we conclude that alpha-synuclein misfolding and aggregation starts in the brain and spreads out, or does it start in the periphery and move in? And I don't know if this data is strongly in support of one or the other. I will say that to me, this data does suggest that there's clearly a difference molecularly with alpha-synuclein in these two disease groups. I think that is safe to say. We already have that sense from the brain studies. We know the oligodendrocytes are affected in MSA and are not in PD subjects. And so we already know that there's some molecular difference here. And yet here's another example of, in the periphery, a very different activity of phosphorylated synuclein in these two disease groups.
And also what the cutaneous synuclein is doing clinically is another interesting question. They got into that a little bit when they described that in general for both the MSA and PD cohorts, that phosphosynuclein levels quantified correlated with a lot of the different autonomic markers that they measured clinically. But it'd also be interesting to know if there's other significance to this peripheral.
Yeah, that was very, very good data shown, and we didn't talk a lot about that. But yes, that they we're able to show the phosphorylated synuclein levels correlate with these autonomic measures. So, taking away from this, I mean, how are we ready to use these kind of markers in clinical practice? Is there a role perhaps for combining something like this with autonomic measures, with perhaps family history, with clinical dysautonomia and symptoms of that at that early evaluation point? And maybe there is a role that you could combine all these factors, create a predictive model, and then say in 1 year from the time the person's first seen, had a biopsy done, to 1 year later, can you predict which ones will end up having MSA and which ones don't? I think that would be huge for the field if we could do it.
And in terms of kind of wish list for future studies and where this would go, a longitudinal analysis looking at people early on and repeating biopsies over time would be really informative. Any other kind of directions that you think the field should go based on this study or something?
Yeah, I think actually your idea is a great one to look over time to see how static are these changes. Do they fluctuate? I think that would be very important. There's a part of me that wonders, can we isolate the synuclein from skin? We don't have to prepare frozen sections. We could take fresh skin and look at that molecularly. Can we determine if there's a difference in the activity of synuclein in these skin biopsies? If you look at cellular measures, other biochemical measures of fibrillization, I think that'd be cool. But the real thing I think is, should we take this kind of assay, put it in the hands of clinicians, and then follow people over time, see the impact in their clinical decision making? I think that would be really interesting. I don't know if we're totally ready, but we're getting really moving in that direction.
Yeah, there's some practical issues that we'd have to think about too, about getting biopsies from multiple sites, or whether patients have a neuropathy that could complicate some of these things. But it definitely seems like a nice contribution to the field of biomarkers and trying to differentiate between these synucleinopathies over time.
Yeah.
Well, thanks for going through this paper with me. There's a lot of interesting things to discuss and take away, and I hope that the audience got something from it as well. Thank you all for joining.
Yeah, thanks for joining, and hope to see you on the next one.